Mr. Provider, we are ready to start the session.
Yeah, okay,
Okay,
thank you.
perfect.
Hereby I open this academic ceremony in which Pablo Rodriguez Feria will defend the academic thesis, Leadership in Colombian Undergraduate Medical Education. May I invite you to present a summary of your study and the conclusions of your thesis.
May I start?
Yes.
Dear members of the committee and other individuals, I would like to present my PhD thesis about leadership in Colombian undergraduate medical education. I would like to show the milestone of the urgency about leadership development in undergraduate medical education in Colombia and other PAHO member states. Everything started in the 90s when the Pan American Health Organization published the core competencies for public health. And in this document, leadership competencies were important for the government personnel, including physicians. In 2008, the same organization wrote the document Renewing Primary Healthcare in the Americas. And in this time, PAHO provided leadership competencies for physicians. In 2010, Julio Frank wrote the first document about transforming education to strengthen health systems in an interdependent world. And the main component was leadership competencies in the health workforce, including physicians. In 2014, Alison Webb conducted the first systematic review for the best practices in leadership training in undergraduate medical education. In 2015, Sanchez Medidiola wrote the first document in Spanish for Latin America about teaching and assessing leadership in medicine. The three next documents are the normative documents for Colombia, for the Colombian government expressing the urgency. The first document was in 2016, the profile and the professional competencies in health. This document is important because the education has to be based in competency-based education, but leadership was not included in this document. To resolve this problem, 1 year later, the Colombian government and other interested parties, including medical students and the Ministry of Health, Ministry of Education, hospitals, health insurance, wrote a document about recommendations for transforming medical education in Colombia. And in this point, leadership was an essential component. In 2018, the last normative document, the National Policy for Human Resources in Health expresses the need that physicians and other professionals of the health workforce should have leadership competencies for the following reasons. First, the health system and services have to be strengthened via primary healthcare. Second, to create agents of change. Third, to work with others to engage well-being and health. Nonetheless, these three documents didn't provide a definition for leadership, competencies for leadership education, and a critical road to implement leadership education for undergraduate medical education. Therefore, the aim of this study, of this PhD, was how can undergraduate medical education in Colombia be advanced through the development of leadership competencies to support university curricula aimed at strengthening health systems. The objectives with the chapters to determine who educates medical doctors in leadership, how leadership is defined in competency-based education in academia, to compare leadership competency frameworks used in undergraduate medical education to a standard, the public health leadership competency framework model, to identify methods used to develop them, and provide good practice examples on how to teach leadership in undergraduate medical education, to establish the factors that facilitate or inhibit the teaching of leadership in undergraduate medical education, to explore how leadership is conceptualized by stakeholders interested in leadership education and training in undergraduate medical education in the PAHO member states, to develop public health leadership competencies for knowledge translation. The figure 3, the system frameworks, was used. This was published by Julio Frenk. The system framework has 4 systems: the population, the health system, the labor market, and the education system. This PhD will focus on the health education system, the need, demand, provision, supply of the workforce that is representing in the chapters and in the conceptual model, defining the field, leadership competencies, a critical road to leadership development, a stakeholder engagement, and knowledge translation. The methods. The second and the third chapter was a scoping review. The fourth chapter was a mix between a scoping review and a thematic analysis. Chapter 3 was a stakeholder analysis plus a semi-structured interview. Chapter 6 was a literature review with systematic components plus a Delphi study. The second chapter results. 23 definitions of leadership were identified, and they related to undergraduate medical education and medical education, that is undergraduate medical education plus postgraduate medical education, interprofessional education, that is undergraduate medical education plus the health workforce, and transprofessional education is undergraduate medical education plus professionals that are not included in the health workforce, but those professions have the mission of the health and the well-being. All the definitions were in English. 14 global networks for teaching leadership were identified, mainly in Europe, USA, Canada, and Middle East. Node networks in Spanish-speaking countries. Instructor characteristics, diverse profession, medicine, nurses, journalists, teaching and leadership expertise like PBL, blended education and leadership competencies, and leadership positions in the universities, in the hospitals. The third chapter, 33 frameworks were identified. 28 frameworks were compared against the public health leadership competency framework, and the others were missing frameworks. I couldn't find them. And I compared these 28 frameworks with different domains, such as system thinking, political leadership, leadership communication, leading change, ethics, and professionalism. Those frameworks were done joining the next stakeholders, for example, people that work in the university, medical students, health service providers, experts from education, the general public, organizations, and the methods that were used to create those frameworks. For example, consensus studies, focus groups, interviews, reviews, and surveys. Important in the Julio Frenk model. Why? The need, the demand. So leadership development was for resolving health inequities, public health, for education. Chapter 4, I identify 77 factors that facilitate or inhibit teaching of leadership in undergraduate medical education. And based on them, I develop a critical road, and this road informed program developers how to teach leadership. So everything started with the citational and normative framework that are literature documents for understanding the importance of leadership. Those are the factors. Leadership. Understanding leadership can be taught. Use a definition of leadership. The second is to create networks with people that have different resources, experience. The community is important, like in this factor, engaged learning community. After that, the thematic scope, the purpose of leadership has to be connected to the context and tailored to students' relevance. After that, to whom the target audience, so interprofessional education, transprofessional education, and citizen, to have interprofessional collaboration. After that, expertise, the people that is going to instruct the target audience, and one of the factors was lack of leadership expertise. After that, agreeing in developing a curriculum and educational methods, such as spirit curriculum, integrating leadership into the curriculum, continuous evaluation and revision, developing assessment tools. Chapter 5 is the conceptualization of leadership in Colombia, Latin America, with a Pan-American health components. So the definition has 5 themes. The epicenter is the first and the second theme, because this theme reflects the objective of the health system and services, that physicians have to target individuals, families, and communities' well-being and health via having competencies for the prevention and promotion of the individual, families, and communities, for health risk management, individual, patient care, collective, health promotion, public health, social determinants of health, and environmental determinants of health, and primary health care. The third theme is to differentiate concepts for leadership, leader, boss, management, a good execution of leadership, and a bad one. The theme four is really important. The models for our own signature leadership in the Americas, and a key component was legacy. Legacy is the contribution that everyone has in the organization and in the society. The fifth theme was the health challenges, the need, the demand in Colombia and PAHO member states. The stakeholders knew about the health workforce and their education, and climate crisis is paramount here. Chapter 6 is the leadership competency framework for knowledge translation in public health workforce. That includes undergraduate medical education, interprofessional education, and transprofessional education. It contains 4 frameworks from 4 domains and 22 competencies. Here in this slide, I presented the domains and one example of each domain. So everything started with training and capacity building and change management. Second, communication. Third, engagement, diverse others in public health initiatives and knowledge management. Training and capacity building and change management is important to develop workforce and to manage change in the organization, because it's important change to transform reality. So model effective leadership values. This competence is important for the values. Leadership is for creating good people and good professionals with values including personal consensus values like fairness, patience, or true honesty, and additional self-determinant values like purpose, motivation, power, resilience. Communication, translate board strategies into practical terms for others. Engage diverse others in public health initiatives. Identify and engage stakeholders in interdisciplinary, transdisciplinary, or intersectorial projects to improve public health. Knowledge management, have a clear understanding of governance and stewardship of involved identities and knowledge translation initiatives. Recommendations, to begin with policymakers, to use the critical route to develop educational policies on leadership implementation, considering conceptualization of leadership, the competency frameworks, and to align national norms with the universities to make the connection. Concerning research, to operationalize the critical road to encourage leadership development, conducting qualitative and quantitative methods for contextualizing, implementing, and evaluating the conceptualization of leadership, the framework, and factors that may influence the critical road to adapt it. With respect to the education, to examine the components from the critical road, to consider the definition of leadership and the framework, to review the competencies that are already included in the curricula, because universities have a history, so they didn't start with a zero. Conclusion, critical road for leadership in undergraduate medical education is an important tool that can be used in PAHO member states to develop leadership programs, not only for physicians, but also for health professionals and transprofessional education. Conceptualization of leadership education needs to be based on contextual factors. Knowledge translation can support transferability on the results from this research. The implementation of leadership in undergraduate medical education should be supported by a specialized network, professional organization, policy makers, and educators to make it happen. The impact, I was contacted to collaborate with very influential organizations like Horas Conju, that is from Los Andes, all the countries from Los Andes, and this Horas Conju create a link, a bridge between 6 PAHO member states. I'm going to mention them after. The Lancet Commission, Education of Health Professionals like Julio Frenk, universities and hospitals that join a School of Medicine, PAHO, Ministries of Health. 6 ministries of health with cooperation with Horas Conju agree to use our evidence to inform policy in their countries for medical schools and Ministry of Health, including Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. Indeed, Colombia has reviewed the conceptualization and the competencies framework because the Ministry of Health is updating the national policy. The Ministry of Health are the link with the medical schools. And a potential impact and dissemination in numbers is that in 2024, these 6 countries had 169 medical schools, and Colombia had 52 medical schools in that year. The acknowledgement to the people that are in this presentation, and the thematic scope is climate change. So I want to see bugambillas, veraneras that are in my book every day, because mental health is important, the same that environmental determinants of health. Thank you for your time.
Thank you for your presentation. The opposition will be opened by Professor Paulus, Professor Economics of Education and Healthcare at Maastricht University, and Professor Paulus was also member of the assessment committee.
Thank you, dear Pro-Rector. Dear candidate, let me start by congratulating you on your thesis. I think you touched upon a very relevant subject, and therefore I would like to congratulate you and your promotion team with this achievement. You gave a very nice overview of your dissertation, and it all comes down to leadership. And before I ask you my first question, I would like you to read out loud proposition number 8, if you want to.
Yeah. Let me open it, Professor, because for positions I have it here. Okay, so a highly esteemed opposition member, thank you for your words. I am going to read the proposition number 8. It is impossible to educate and train someone in what has not been conceptualized. First, the meaning of leadership in Colombia and the Americas must be understood.
Thank you very much. As you indicate in the proposition, we need a proper concept of leadership. And since your dissertation is on leadership, my first question is the following. Did you have an initial, let's say, definition of leadership? What do you consider leadership yourself? When you started this dissertation, what was your initial definition of leadership?
Highly esteemed opposition. Thank you for your words. And my definition was my initial component was based on the definition that I have from my master in leadership of governance in public health, that was to influence others, to have a vision in common, to create change.
Okay, and that was your initial definition.
Yes.
It is very interesting because if I look at your dissertation and I look at the beautiful review that you conducted in chapter 2, you found 23 conceptualizations of leader and leadership. So 23. What does that imply if we have 23, let's say, definitions, conceptualizations? If I had to teach a course on leadership in medical education and I have 23 conceptualizations, what would I tell the students about leadership then and what leadership is? Could you reflect on that?
Yes, Professor. Thank you for your question. For me, when I was doing the review, I noticed in that moment, I didn't have the interviews, right? So in that moment, when I was doing the review, I noticed that there was 2 types of development: leader development and leadership development. And these 22 definition use them interchangeable. And for me, it's completely different. Leader development is a person, is human capital. Is one person that is going to develop competences in leadership, is going to have a leader position and is going to execute leadership competences. And there is other thing that is leadership development. And for me, leadership development is a social development. Is that everyone should have leadership competences to have a legacy, to create a change in our society.
Yeah.
So I will start my point between leader development and then leadership development, because for me it's key. Then in the definition, in these 22 definitions from leadership, is the context. For me, they mention influence, have a vision, work with others, change, but it's important the need, the demand. Why are we teaching leadership development in our context?
Yeah.
Political context, social context, economical context, technological context, because now we are talking about international artificial intelligence. Today, I read an article in Colombia that now master and PhD with blended education and virtual are more current with more students than that face-to-face programs.
Yeah, I agree with you that context is very important. And I also agree that you say we have the human side and we have the social side, let's say, of leadership. What I missed a bit was leadership style, because you talk about leadership in terms of dimensions such as empathy and inspiration and collaboration. So shouldn't we teach the students in medical education about the leadership style? And which leadership style do you think would be most suitable, given the social context of Colombia?
Thank you, Professor. I agree with you. For me, first, we should have the conceptualization of leadership, the competences, and after that, we can start talking about the leadership styles. Because for me, these leadership styles are worldwide, but they were not developed in Latin America. So for me, the most important type of leadership that we should teach is transformational leadership. Transformational leadership is to know that things can be improved, not to criticize, because I don't believe that we have to destroy. We have to create, to construct, constructivism, to see what points can be better, know that can be changed and transform our society.
Yeah.
So for me, transformational leadership.
Yeah, thank you very
Because,
much.
for example, I disagree with laissez-faire, to leave the others behind and the people do whatever they want. I am against that style.
Yeah, so you're more in favor of a transformational one than, let's say,
Yeah, because I think that we have challenges and we have to transform those challenges.
Yeah. Now, when you found these 23 concepts of leader and leadership, you did that based on a literature review in which you included 6 databases. And one of the 6 databases was an educational database. Can you tell me, were the results that you found primarily from the education database or from the other databases? Like
Professor,
M-base.
to be honest,
Yeah.
to be honest, I cannot answer that question. I didn't look at the specific database and if the leadership definition of leader was for public health or from education or from military.
No, that's fine. That's fine. Let me then ask my final question, also given time. You conducted the data analysis once you gone through the data collection, and it says in your dissertation that all authors contributed. Could you tell us a little bit more about how that process of data analysis went? So you say all authors contributed. Could you tell me a little bit more about that?
Professor, can you remind me, are we talking about which chapter?
Chapter 2 still. Chapter 2, you indicate that you have collected data from 6 databases, and then the
Yes.
that you conducted, it says that all the authors were, let's say, participating in this analysis. So I was wondering how did that go about? How did you do this? And maybe you can
Thank
give
you
a short answer also given time.
Thank you for your question. For me, it's important when I conduct a literature review to avoid cherry picking and to stick with international guidelines. So the process was the 6 databases, then Ryanair. After that, I eliminate duplicated. 2 authors independently read the titles, the abstracts. In case of disagreement, we start talking. And after that, if we have like not agreement, a third person was included. After that, a full text. So we start extracting the data analysis. Was the title, the contact author is important, the aim of the study, the definitions of leadership, the conflict of interest,
Mm-hmm. Yeah.
and the conclusions. And after that, between two independent reviewers.
Yeah. So you use 2 reviewers basically each time.
Yes.
Good.
Yes.
Thank you.
Each time.
Yeah.
The first one, I extracted the information, and the second one reviewed the information.
Very good.
Also, it's important quality appraisal, because based on EBIPNet, that is evidence-informed policy networks, it's important to have a good quality of the evidence. So also I applied risk of bias for qualitative, quantitative, rich methods, and great literature.
Yeah, I couldn't agree more. Thank you very much for answering my questions. I give the floor back to the prorector. Thank you.
Thank you. The opposition will be continued by Dr. Grimaud, Senior Lecturer and Researcher in Public Health at the French School of Public Health in Rennes in France. Dr. Grimaud was also member of the assessment committee.
Thank you, Mr. Prorector. Thank you very much, dear candidate. I must say, as public health and medical epidemiologist, I learned a lot reading your report. Was very impressed, and I think your presentation is really illustrative of the amount of work that you produce and the breadth of the concept that you explored and you work and I think I started with my first question, which is sorry, I just have got a little signal on my Zoom. This thing to my first question, because you I didn't know very much about leadership apart from, despite being a good friend of Professor Slabanowska, and I discovered with pleasure all the concepts the definitions you explored, and especially the dual dimension of leadership, the collective and the individual one. And my first question relates to that, whether I would like you just to go again to these 2 different concepts, the collective individual leadership concept, and to give me your appreciation of which one is the most appropriate to be taught to undergraduate medical students.
Dear highly esteemed opponent, thank you for your question. If in Colombia and in other countries in Latin America, we are going to teach leadership education, my proposal is to use the conceptualization that we have provided in this study. First, because we conducted a stakeholder analysis that had been used by PAHO member states for more than 3 decades. Also, we semi-structured interviews with different stakeholders from Canada to Chile with different academic background. Even medical students were involved, physicians, nurses, people with a master in education, in policy management, with a physician that did a residency, a fellow, a master in public health, in epidemiology. So definitely I will use the conceptualization of leadership that I propose with the descriptors. After that, Professor, the idea is that this conceptualization is going to change based on the experience, because we have not implemented yet. So after we implement it and we make qualitative and quantitative studies to update or to change a little bit the conceptualization. I will not use the...
Could I just interrupt you? My question is really the duality between individual leadership skills and collective leadership skills, and that was my question really. Whether both should be taught. There are both complementary. I'd imagine that's an answer. But especially at the undergraduate medical level, which one should you focus on? Is there an argument, or maybe there isn't? It could be an open question. We can discuss about it.
Professor, I thank you for clarifying the question.
Right.
I will focus first in the individual competencies with values. For me, first, you have to be a person with integrity, with values, to be a good person for the society, and after that, a good professional. Having emphasis on the values of the person, because we can have competencies in communication, in engaging, but if we have wrong values, then it's a bad execution of leadership.
Okay, thank you very much. That's clear now to me. My second questions relate to the fact that I think your PhD could be a PhD in educational sciences. Could it be I think it nearly could. And you understand why I have made this comment is my question is about the transferability of what you learned doing this work on leadership skill training in medical education. How much what you've learned during this work will be transferable to other areas of higher education other than medicine? So do you think you've learned things that could be applied somewhere else, basically, in other disciplines?
Thank you for your question about transferability. I have different comments for this question. The first one, the transferability for the scoping review. We have the evidence, and it's important to know the state of art. So anyone can use the results from the scoping review. After that, the critical road, we have the coding. So others can adapt the coding and create their own critical road. For the interviews, we cannot generalize, but we can transfer the protocol. We already have the questions, and people can use those questions for future research, and also can use our definition. For different disciplines, of course, the beginning, what the epicenter was medicine. But one of the propositions for Julio Frank is that we need to avoid professional silos. And leadership has to be a connection between other professions. That's why, since the beginning, I start proposing undergraduate medical education, because we have to start by a profession. Then health workforce, interprofessional education, transprofessional education. And the only part that I think that is not transferable, my PhD, is for the general public, because in Colombia or in Latin America, only the 20% can go to a university. So it's how we are going to integrate the society with an occupation, because they work with an occupation, to create a better society. Because one of the parts for the primary healthcare for the PAHO in 2020 is the social participation and the social mobilization. So citizens, without matter the educational degree, should have leadership competencies to transform our society. Because with professionals, it's not enough.
Okay. Thank you very much for your answer.
Thank you. The opposition will be continued by Dr. Martinez Tapia, physiologist at the National Autonomous University of Mexico. Dr. Martinez Tapia was also member of the assessment committee.
Thank you, Doctor. First of all, I would like to begin by congratulating the candidate. It has truly been a pleasure to read your thesis on leadership in Colombia, which also, I think, offers a much needed and a thoughtful analysis of the broader situation in Latin America and the Caribbean. So I also want to acknowledge the clarity and precision of your presentation. It was both insightful and very well delivered. So as you know, in many universities across our region, leadership in the health science still receives limited attention. So that's why my question will focus on this regional perspective. Okay, so the first thing I would like to ask is next. In your proposal for normative frameworks, how would you ensure that leadership development programs designed in Colombia could be transferable to other Latin America and Caribbean countries, especially considering the region's wide political, economic, and historical diversity? So this diversity means proposing leadership programs can look very different depending on the country. So that's my first question.
Dear highly esteemed member, thank you for your question. In the chapter with the critical road, we use the systematic component. The critical road has been used by PAHO and PAHO member states since the 90s. So the critical road integrates the most important factors to develop leadership. So the first one is the situational and normative framework, as you mentioned. And the systematic component has 4 parts, right? The contextual, that is the input. After that, we have the structural factors and the process, how these factors that make the structure will work. And after that is the outcome and the impact. So for the contextual input for any PAHO member state, we need to know the international norms, the international commitments, like PAHO or Horas Conjunto. What are the norms of PAHO and Horas Conjunto about leadership, education, and training? Do they have leadership definition, a framework based on competencies, because we need the competencies, based on competencies to develop leadership? After that, the government is national norms. The national norms, the government, the Ministry of Health has a document that links with international norms about the definition and the competencies. The third component for the contextual factor is the academic community. Is the academic community, the universities, because the universities have the curricular committee. As in the curricular committee, the university vision has leadership development and how they are going to do it, strategic plans. And after that, the professors, for the contextual, are the professors following the advice about leadership development? Then is the structural. Do we have the norms? Do we have the process to do it, to implement it? Because, okay, leadership development, but how to do it? Do we have the structure to implement national norms for leadership development? After that is the process. The process will be the percentage of implementation of the documents. And also in the normative and situational programs, we need to provide the factors that facilitate or inhibit the process. And the outcome will be a control panel tool. We do that with vaccination, a control panel tool, with all the Latin American countries. And by each country, Mexico, Chile, do they have a normative framework? Do they have situational framework? A clear conceptualization of leadership? A clear competency-based education framework that align with international requirements? And I will do it in that way. And also to compare countries. For me, it's important to compare Mexico with countries in Latin America to create a comparative analysis and a neat analysis.
Okay, thank you. Well, I'm going to. What do you think? Because not all the universities, even that it's an alignment and it's a framework. Not all the universities teach or has their curricula with competencies. There are still examples that still thought, for example, medicine by objectives. So this is a really great barrier. What do you think?
Hi, listening member, I agree with you. Not every university has education based on competencies, and we have to work on that. Based on leadership development, I will cite the 8 steps of Kotter's for change. The first is to increase the urgency. Increase the urgency. Why competency-based education is important, and why to shift the paradigm of education, of outcome-based education to competency-based education for the knowledge, the attitudes, the values, the skills. After that, building a coalition that we are doing, working with Horas Conjunto, with people from the Land Commission, policymakers, universities from Canada to Chile. After that, we need to create a vision for change based on values. We need to have a small sentence why competencies is important. After that, we need to communicate for buy-in, to make to join more people to work with us. After that, empower action. We need to know who is resisting to the change and why. Why these universities in the curricular committee and the professors are not willing to teach and train in undergraduate medical education based on competencies.
Okay, so you
Check,
talk about an
check
insight,
the barriers and resolve them. After that, the 6th step is create short-term wins, build on change is important, and ensure the change in the culture. So I will use a theory of change to shift from outcome to competency-based education.
Okay, okay. Thank you, thank you. My last question is about, well, given the significant diversity and fragmentation of the health system across Latin America and Caribbean, and the Caribbean region, and considering that one of the limitations of your thesis is the lack of applied research in these systems, what methodology would you recommend to evaluate whether students trained in leadership actually make a positive impact in a such variety health systems, health settings? Sorry.
Thank you for your question. Actually, I have been working with the 6 PAHO member states to know the need of each member state about leadership development in undergraduate medical education. So what I did was to provide a document with the conceptualization of leadership, the competences, and the needs that the governments have. After that, each government prioritized the competencies that they need to change reality. The question about positive impact, how to do it, for me is the need that they have, and after some time, we are going to evaluate how primary care, because that's PAHO member states, right? How the health system and services are better based on primary healthcare. I will do it in that way. How to develop promotion and prevention strategies in the family, in the individuals, family and communities, in the community to have a better health and well-being to them. But
Okay.
I think that's some years after this PhD.
Yeah, definitely. Okay, so you talk about to work with the family or the base of our society, right? No, so it's a really big job. It's,
Mhm.
so it's quite interesting. Well, thank you to the candidate and thank you for rector. Thank you.
Thank you. The opposition will be continued by Dr. Brouwer, Director. She collaborates at the School of Health Profession Education at Maastricht University.
Thank you, Pro-Rector. Dear candidate, I also would like to join the other opponents in congratulating you and your supervisory team on your thesis. I think it's already making an impact if I read how much political engagement you have reached during doing this research. And thank you also for teaching me about your culture. I loved learning about the instruments and the dances, and I would recommend everyone to look up the tiple and the cumbia on YouTube. In my work, I often work with medical schools in globally different countries who will approach our School of Health Professions Education to guide curriculum redesign or faculty development. And through this work and also through my research, I became particularly interested in the tension between globalization and contextualization in medical education. And I would love to engage in a bit of a discussion with you and hear some of your thoughts and findings on this issue. So my first question is, again, around this concept of leadership. Based on your research, do you believe that leadership for healthcare workers is a global competency or a more local contextualized one? And more specifically, can you name some examples of domains or specific competencies in your proposed framework that are universal? Some that may be specific to the Latin American Caribbean region, and some may be specific to the Colombian national context.
Highly esteemed opponent, thank you for your question. Actually, today I read an article from you about internationalization of medical education, and I agree with you. For me, leadership is a global. For me, is for the World Health Organization in every region foster and wants leadership for the system, for any system, and people work in that system, physicians and people with other professions. So I think that leadership is a global component, but have a specific variations between different regions. And for me, the reason why is the methods that we used and when we create the conceptualization. Because for me, so humanity is a social construction. So every time for me, the concepts and how to teach them is changing. So for me, something that is global is to influence others, to work with others, to create a vision, change. Then is the specific parts that, for example, in our definition, legacy. I review these 22 competencies, nothing about legacy. And this person say legacy is important for our society. It's our contribution in the organization, because sometimes we are going to leave the organization, maybe because we are retired or we change for another position. So it's the contribution that we left. In the Americas, for me, one of the best frameworks that I like is LEADS. LEADS was created in Canada. It's for leadership development. Is interprofessional education. So I like it. The other one is CanMeds, but CanMeds is more for medicine. So I disagree with frameworks that are only for physicians, because for me, leadership should be for every person without matter the profession. So LEADS, for example, LEADS is an acronym, right? So lead self. The E is engage others. So we can see that this domain of engage others is directly linked with our domain from engage diverse others in public health initiatives. After that is develop coalitions.
Can I interrupt you, dear candidate? Thanks, because I'm happy already with that answer, and I would like to have some time to take you on a small adventure with me. Just earlier today, this is very true, this is not made up, I was in a meeting with a medical school in Venezuela, in Caracas. And this was a very first meeting, a very get to know each other, but they are about to do a curriculum change, and your supervisor is aware of this. Now let's assume that we are a few months ahead in the process. This was just a first meeting, but let's assume we go ahead a few months and we agree on a joint project regarding curriculum design. Let's also assume they are on board with the importance of leadership as part of a curriculum redesign. And let's assume we have done the first couple of steps, because I want to follow up on the previous opponent of establishing this conceptualization discussion with all the stakeholders and the political goodwill, maybe. Can you think along with me, how now do we think around the curriculum? You mentioned we talk about teaching methods, we think about assessment, we think about instructional design and alignment here. In the course of your research or your experience, what are some teaching activities, teaching and learning activities for undergraduate students that will really help them develop these leadership competencies that we've been talking about?
Thank you for your question. Based on the review from the literature and our interviews, mentoring is important for a career development. In Colombia, medicine is 6 years, 7 years. So career development is really important, because for me, leadership should start from the beginning. The second one is coaching. Coaching is to develop specific competencies in a short period of time. Important role model with a good execution of leadership and a bad execution of leadership based on values, because it's important. It's important. Formal curriculum, informal curriculum, that is what is not written but people are doing, and hidden curriculum, what a student can see. And there are physicians with power, with a leader position, but with values that are not good. So they have to have role models and to identify which examples are good for the society and which examples they should not follow. Because we can teach about leadership and have formal curriculum, but then they see the role models with bad execution, and it's difficult. For me, also is important simulation exercise about leadership. Case-based and project-based, because we need to integrate the community. hospitals and universities are not alone. They have a neighborhood. A neighborhood that can be like in the university that I work, that is a low social class. So it's important to integrate the community that they see what they are doing and contribute to the well-being and the health outside the hospital, because we need to also move medical students from the point that everything is in a hospital. No way. Public health, the well-being and health is in the daily life. And the main purpose for leadership development is to change reality in the communities, and more if our communities that are vulnerable.
Thank you. Thank you. You see me nodding. I am very pleased with that answer. Do I have time for a final short question, Pro-Rector, or is this the end of my time?
Sure.
Because, thank you, a short question, hopefully, triggered by this answer, and knowing that a PhD journey is also an education to become an independent researcher. And as much as I have seen, and today you show what you learned in terms of research skills, I am sure that you also picked up leadership skills. And I wonder if you could briefly reflect with us what were the most important leadership skills or competencies that you gained during this PhD journey.
Thank you for your question. For me, the most important leadership competency for me was communicating with others. I am completely technical with the technical words and everything, and the PhD was in English. So when I was talking with the Ministry of Health from every country in Latin America is different. For example, in Colombia, we say human talent for health. If you say in Colombia, human resources for health, we don't like them because resources mean exploitation. So first, we're humans and we have talent. So how to communicate briefly with politicians, my research in Spanish, to tailor to their needs was the most challenging. The same as this presentation, I did like 7, 8 versions. So communication skills.
Thank you. Thank you. I give the word back to the Pro-Rector.
Thank you. The opposition will be continued by Professor Pavlova, Professor Health Economics and Equity at Maastricht University. Professor Pavlova is also the secretary of this degree committee.
Dear candidate, my congratulations to you and to your supervisory team for this important dissertation. Your dissertation focuses on the development of competency-based leadership framework with the aim to enhance medical education. And the topic is highly relevant, not only for Colombia, but also for many countries around the globe, not to mention probably for each and every country around the globe. Yeah, because we have challenges with regards to shortage of resources, but also changing sectors, changing healthcare sector, changing demands, and definitely we need also to adjust the medical education to be able to prepare skilled and well-equipped human talents for the future. This confirms very much the importance and the value of your dissertation, which we do not doubt. I will be happy to discuss with you some of the implications which are based on your dissertations. I thought I could see at least 2 important implications. And as you write in your dissertation, for example, you advocate for leadership and interprofessional collaboration. And this is, as you explained, this is important because it will help to break professional silos and transform the medical education system into a better education system. Now, I think definitely there is sufficient base in your chapters for such inspiring recommendations. But I was wondering how feasible are they? We know very well that health professionals can have different motivation, different values, different professional values. How feasible is to expect that they're going to collaborate in a way that will allow to actually improve medical education. Do you see any challenges, how they can be overcome? And you can take, for example, Colombia as a case in this question.
Highly esteemed member, thank you for your words. How feasible is the PhD in Colombia? Based on the critical role, the first component is the normative framework. So right now, I am working with the Ministry of Health in renewing, updating, modifying the new national policy for the human health workforce. And we are going to include leadership definitions and leadership competencies. After that is how to, we work closely with ASCOFAME, that is the Association of Medical Schools in Colombia, all the medical schools. So we can create a connection between the Ministry of Health, ASCOFAME, that is going to create a link with each university. After that, having meetings with the university, the Faculty of Medicine, that they have the curricular committee, and how the curricular committee is going to integrate some competencies, because for me, all the 22 competencies is a dream. So I would, is how each university is going to prioritize the competencies, because Colombia is multi-ethnic. One thing is being in Bogota, other thing is being in the Amazon jungle, where everyone is a first native and they don't even have nationality. They are Brazilians, Peruvians, and Colombians, or Guajira close to Venezuela. How to integrate with each university, how to identify people from the curricular committee or professors that are not willing to teach leadership, because for them can be extra work, or they don't have the competencies for teach leadership, or they don't have competencies for education. So it's how to see those factors that inhibit teaching, and then how to resolve them. It's going to be a challenge, Professor.
I'm very happy to hear that you have already thought about that it is not going to be easy, but still that is important. I was wondering, seeing the time I have, I will go to my third question, because I thought that is probably more important. I want you to take a bit different look at your work, and instead to focus on the educator, to take the perspective of the students, of the users of the education services. We know that continuously improving the medical education is important, but how these kind of improvements could reflect on the learning experience of the students, because there is some learning curve on the side of the educators. Have you thought about that? What would be the impact of these kind of changes on the students?
Professor, can you clarify the question? The question is for how to improve educators' competences, how to teach the trainers to have better experience to the students.
You want to change the education system for better. That is all clear. But this will mean that there should be some adjustments in the education, in the form of education. Like, for example, instead of lecture-based teaching, maybe you propose some kind of problem-based teaching to train better competencies. These kind of changes, how they would reflect on the students? Wouldn't that create some uncertainty?
Thank you for your question. For me, the first adjustment that I will do is to characterize the curriculum, to see what is teaching in the curriculum, why people may think, for me, the first barrier is that the curriculum is oversaturated. So why is oversaturated? To implement leadership in longitudinal component.
Pablo Rodriguez Feria, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return.
We are complete, Professor Etos.
Okay, it's okay now. Pablo Rodriguez Feria, the degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Shabanovska is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you, Prorector. Dear Pablo Rodriguez Feria, do you promise to work in accordance with principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Pablo Rodriguez Feria, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university shown by the beadle.
Thank you.
And now, a little pleasure and reflection. I will give the laudatio to Dr. Pablo Rodriguez. Dear Dr. Rodriguez Feria, on behalf of the supervisory team, Professor Sue Babbage, Dr. Luis Jorge, and myself, I feel privileged and delighted to give this laudatio to acknowledge your scientific achievement, which is a PhD degree from Maastricht University. I am grateful that we could accompany you throughout this academic journey, during which you let us know you as an academic, scholar, colleague, and a friend. When you journey together, you recognize, admire, and want to enhance the qualities which are so unique and make your academic journey, dear Pablo, so special. And these are patience, determination, trustworthiness, kindness, research drive, academic integrity, research curiosity and passion, ability to bring people together, always aiming high, showing that borders do not exist in science, advocacy for the cause you believe in, great collegiality and humanity. I got to know you as our master's student, a holder of a prestigious Erasmus Mundus joint diploma grant from the European Commission. Your interventions and contributions during the program caught my attention of you as an authentic leader with an analytical and creative mind. You have proved your research talent writing your master thesis, which was published and then continued with PhD in the educational leadership area. Again, you were granted a prestigious PhD grant from the Colombian government. We greatly enjoyed the experience of working with you on academic, professional, personal, and inspirational levels. Academically, you have designed and crafted a very detailed study. Each step was logical and needed. You were discovering a new land and building the knowledge base from the scratch. Every step was always thorough and in-depth. You mastered all types of reviews and developed as a recognized expert, serving as an associate editor in the Public Health Reviews and International Journal of Public Health, building trust in your work among colleagues. Professionally, you have developed a team of researchers and helped your colleagues develop and grow with you. You have taught and mentored our students who extremely valued your teaching and contact with you. You have shown great professional potential by contacting and bringing important educational and policy stakeholders to express the interest and see value in your work, such as Julio Frank and Laura Magana. Personally, I valued our meetings and discussions. You were always kind, respectful, acknowledging that we are all busy academics and have many deadlines. I loved when you said, "No worry, Professor Kasia, take it easy. We can meet when you are ready." Thank you for this, Pablo. Finally, there is something very inspirational about you, Pablo. This is your love for nature, history, geography, and other human beings. I learned a lot from you about Colombian birds who are protected and can graze on coffee fields, about an indigenous tribe in Colombia, which is run solely by women, about flowers, climate, and people. Moreover, you always know something about other countries, etymology of words and names, which make it fascinating to converse with you. You took me on a journey to Colombia to find out how to develop and implement leadership in medical education, and we ended up traveling through all PAHO member states and Americas. Dear Pablo, your journey to obtain the PhD degree is finished, but the world is open for you to move on and make a big change.
Dear
Thank you for your
Dr.
words.
Rodriguez Feria, also on behalf of Maastricht University and the Board of Deans, I congratulate you with the degree you just have acquired. And we wish, as already expressed by your supervisor, all the best in your future career as a researcher and as a policymaker. I hereby declare this ceremony ended.
I would like to thank the Prorector for chairing this ceremony. I would like to thank all members of the assessment committee and of the opposition for your questions and for the discussion with Dr. Pablo Rodriguez.
Thank you.
I would like to thank the co-promoters who were there always by Pablo's side. Dr.